a lot of questions about the vaccines, and there's a lot of information out there that can be confusing. And we thought that this was a good opportunity to create a town hall so that we can kind of have like an informal discussion about some of the things that you may want answered. So I asked Prak, Naik, who is a PHARMD that works or owns the drugstore at Perrysburg, who is well-versed in vaccines. And also I asked Dr. Joel Kammeyer, he's one of the professors at University of Toledo in the Department of Infectious Disease, who has been in the front lines working with these COVID patients. And you know, I'm gonna turn it over to Joel. He's got a small presentation, and then after that, Prak will speak.
Thank you. This is always the hard part where I have to figure out how to share my screen. Did you see my screen?
Not yet.
No, not yet.
All right. Zoom is always a little challenging for me. Srini, where exactly?
It's on the top. If you look on the top, it says a green button that says share screen. Yes. Next to the mute button, stop video. But on a computer, it may be different.
It's on the computer. It's at the bottom. So if you go if you move your mouse to the bottom, control should show up, and there should be a green share screen.
Oh goodness!
Do you see that?
There's neither of those things.
Do you know how to mute on the computer?
Yep.
Is there a mute button?
I have the mute.
And right next to it should be.
It says more.
Yeah. Click on more.
Okay. Participants, invite, chat, record on this computer.
Okay, let me try making him a co-host.
Okay. Thank you.
Okay, you're a co-host now. Can you try?
I think I've got something here. Hang on.
There you go. I think it's there. You go.
Okay.
Perfect.
Close. Okay. I wanted to thank Srini and everyone for inviting me. We've tried to do a few town halls along these lines because I know that there's a lot of questions out there and that there's a lot of misinformation. And the more people and the more groups that we reach, where we're really able to have these small group sessions, I think it's very helpful in overcoming some of the hesitancy that many people have around vaccines. So I've done a few sessions like this, and I'm going to be doing a few more. I'm going to chat for about 10 minutes and then leave it open for any questions that you have about the vaccines or about any other questions regarding COVID-19. So I don't have anything to disclose. And I want to begin by just explaining a little bit about the COVID-19 vaccine itself. Now, I know in an audience like this, there will be quite a few different levels of understanding that we come to a discussion like this regarding the vaccine. I know that some of you are probably as expert as I or Srini happen to be, and I know that others will have a very new understanding of these vaccines. So as we get to the question and answer part, please don't hesitate with any questions that you might have. In my mind, the most important part of the COVID-19 vaccines to understand is that they're a very new and different technology than has been used in vaccines. So I think when most of us think about a vaccine, we think about the introduction of a live virus and the body builds up immunity in response to the threat of the virus that's being introduced. This is very different. This is not a live virus vaccine. This is a technology that has been used in cancer treatment And what happens here is that the vaccine introduces mRNA, which is incorporated into our cells. And our cellular structure is tricked into building a spike protein. Now, if you've been following COVID-19 over the last 10 or 11 months, you've probably heard that phrase, spike protein. The spike protein is on the SARS-CoV-2 virus. That's the attachment protein that allows it to attach to our cells, all right? And so the mRNA vaccine incorporates into our cells and tricks our cells into building a fake spike protein, a mimic of the COVID-19 spike protein, but it's completely harmless. And so what happens though, is that our immune systems recognize that our cells are carrying the spike protein, which kind of looks like COVID-19, and our immune systems are tricked into starting to generate antibodies against the against COVID-19 because they see the spike protein and they realize that there's a foreign intruder. And so our immune systems then kick into overdrive, and that's how we build up immunity to COVID-19. So it's a new and different technology that hasn't been used in vaccine development, but it's really creative and ingenious that they've been able to kind of create a mimic protein that helps us to build immunity against COVID-19 should we come into contact with COVID-19 in the future. I'm going to just talk about two studies very quickly and some of the highlights of the two studies about the two vaccines. Because I think that as we think about the questions that all of us have with regards to the vaccines, understanding what was studied is a really good way of kind of getting a starting point for understanding what the vaccines do and don't do. So this is the study published about 3.5 weeks ago regarding the Pfizer vaccine. In the Pfizer vaccine, they enrolled 43,500 patients, and about half received the vaccine, about half received placebo. With any vaccine study, there's always a question of, have they recruited volunteers that are representative of the larger communities? And so in the Pfizer study, they reported that 42% of their participants were over the age of 55, which is of course important, given that so much of the COVID-19 pandemic has really fallen on the shoulders of older persons. There was a pretty split gender balance. They reported out the African-American and Hispanic populations that were enrolled in the study. I did not see data on Asian American or Indian American populations that was reported, but there was an effort to make sure that the groups were representative. And the studies also had obese patients and other patients with underlying medical conditions, again, trying to be as representative of the population itself. And these are the beautiful curves that have demonstrated what happened in patients that took the vaccine. The flat red line at the bottom is the number of patients that got COVID-19 after having obtained the vaccine. So a few people did get COVID-19, but obviously a much smaller number than the blue diagonal line, which represents the patients that got the placebo. So as you see with the blue diagonal line, those patients continue to have COVID-19 cases steadily as they were just essentially part of the general population. The patients that received the vaccine trial in the red line had just a much, much lower incidence of COVID-19. So in total, 162 cases of COVID-19 in the placebo group, only 8 in the vaccine group. So the vaccine was about 95% effective. With that said, there are side effects. And one of the points that I always emphasize is that most patients have side effects. 93% after the first dose, 88% after the second dose. They kind of broke this out between younger patients and older patients. In fact, it was younger patients that were more likely to experience side effects than older patients, which I think is a little counterintuitive to what we might expect. There were some patients that had fever, 1 out of 6 patients in the younger group, 1 out of 8 patients in the older group. And occasionally those fevers were very high. These were all side effects. And one of the points that I tell my patients is that we can expect side effects. It means that your immune system is doing what it's supposed to do. It's building the antibodies, and it means that you're, it doesn't mean that you have COVID-19. It doesn't mean that you're sick, but it just is a signal that your body is kicking into overdrive and building the immunity that we have. Side effects are expected. They're not the exception. They could be expected with the vaccines. And then I'll just touch on the Moderna vaccine as well, published right about at the same time. Again, 30,000 participants. The Moderna vaccine had 99 sites. So this was a very large geographic area. And they split evenly who got the vaccine and who got placebo. Average age, 51 years, right about half male and female. 25% were older than age 65. 1 out of 6 patients had predisposing medical conditions. And again, efforts to recruit a diverse population. They reported out the African American and Hispanic populations. They didn't report numbers on Asian American or Indian American populations, but there was an effort to try and recruit a population that looks like the population at large. And again, a very similar curve. On the bottom, the number of patients that received the vaccine, after 4 months, only 11 cases of COVID-19 in the vaccine group. The diagonal gray line, that's the placebo group, the patients that didn't get the vaccine, 196 cases. And so the Moderna vaccine, 94.1% efficacious in preventing COVID-19. Not 100%, but very significant reductions. Also with the Moderna vaccine, they published data as to the number of patients who got the Moderna vaccine who had severe COVID-19. And they reported no cases of severe COVID-19 in the vaccine group. So the 11 patients that got it, none of them had severe disease. So when we think about changing the course of the pandemic, reducing the number of cases is a wonderful thing. Getting the severe cases to 0 is absolutely terrific, because that would mean a dramatic reduction in the number of deaths in the vaccinated patients. And again, I'll just make the point that with the Moderna vaccine as well, 84% had a side effect after the first dose, 88% had a side effect after the second dose. Everyone in my division except myself, I think, had their second dose on Tuesday. And on our text message list on Wednesday, everyone was saying, I don't feel good. So that's expected. And the side effects can last 2 to 3 days. It can, most commonly, it's just some pain at the site of the injection, redness, warmth, and tenderness. But there can be side effects that can even be 7 or 8 days later. And there can be side effects that include fever and a lot of fatigue. Most patients that have side effects are experiencing quite a bit of fatigue. Once again, those are expected side effects and nothing to be worried about. They pass within a couple of days. Some patients with the Moderna have had, even a little bit more of a severe manifestation. But again, it's extraordinarily rare that patients have anything more than just these simple side effects with the vaccine. So I'm going to pause because I promised that I was going to do maybe about 10 minutes to get us started. And Prak and Srini and I will take questions from anyone that has any kinds of questions.
Okay, so Prak, would you like to make any comments before we go to the question and answer session?
You're on mute, I think.
Prak?
There we go. Sorry.
Ah, there we go.
There's that.
No,
Yeah, sorry. So yeah,
okay.
what I was saying was the biggest thing I can start with is that it's really important for everyone to feel comfortable that we don't have all the answers, and we may have lots of questions because this is new technology, and as well as this is new experiences for everyone, even those of us in the healthcare field. So there's no dumb questions, and it's an ever-changing process. So I think it's really important that we continuously ask questions and try to gather information as we kind of work our way towards getting vaccinated and hopefully moving past the pandemic and so forth. So I think it's really important, and it's really good that we're having these town halls because I think it gives people opportunity to ask questions, and that's what we're here for.
Okay, everyone out there, if you guys can come up with more questions. We did have some preliminary questions that were submitted to us.
Once again, sorry to interrupt you. If Dr. Joel can stop his screen share, then we can see you.
Okay. It's at the bottom. Okay, there we go. All right.
Thank you.
Perfect. Thank you. So I think one of the, I think my patients ask a lot of this question. I think you might have answered it in your presentation, but one of the biggest question is, can I get COVID-19 with getting the vaccine? Like some people say that, I get a flu shot, I got the flu and I won't take it.
No, so with the way that the vaccine is designed, there's no COVID-19 that is introduced into the body, right? And so there's no mechanism by which anyone could get COVID-19 from the vaccine. It's also true about influenza, by the way. You can't get influenza from the influenza vaccine.
Of course.
There are times in which we have heard anecdotes about people who did end up getting COVID-19 after the vaccine. And that is not because of the vaccine. It's because of one of two things. Either they were infected in the 1 or 2 days prior to getting the vaccine, and then they got the vaccine, and 2 or 3 days later, they started having symptoms. But it could also mean that, especially in those first days, when patients are just generating the immune response, our immune systems are not fully primed until after the second dose. And so some patients that have gotten COVID-19 after the vaccine, that's to be expected because the immune system isn't fully ready to go right away after that first dose. So they contracted it from someone in their community, but it doesn't mean that they got it from the vaccine.
So this will lead into my next question, Prak, maybe you can answer. So what is the protection offered? I know there's been reported that after the first vaccine, you get 50% or so, but what is your recommendation or your opinion about how much you're protected after the first dose and how much are you protected after the second dose of the vaccine?
Sure, right. And this goes for both of the Moderna as well as the Pfizer vaccines. So what they're estimating is around 50% protection after your first dose. And we usually make antibodies about 7 to 10 days after the dose, and it provides some protection. However, it doesn't mean that you're in the clear. And then after your second dose, so that'd be day 21 with the Pfizer and day 28 with the Moderna, then around about 2 weeks after your second dose, then you're looking at up to 95%. And it's really important to know that it's up to 95%. So it's not 100%. And because each individual's immune systems work differently, that's why this is a range. It's not necessarily set that you'll be protected and you're good to go. So with a vaccine, regardless of its first dose or second dose, we still need to do social distancing, wear a mask, wash your hands, and be aware of symptoms, because even with 95% protection, Srini, as you know, that 5% are the patients that keep us up at night. So there is still a chance, and if that 5%, those individuals may be carriers, but they may not exhibit symptoms. So that's really important to know as well, because not everyone's going to be vaccinated in the same window of time.
Right. So I guess these questions that were laid out perfectly, because they kind of tied one after another. So if I get vaccinated, is the question, am I able to spread the virus? So if I come into contact, even though I don't get sick, can I give it to someone else? Can you be a carrier?
Absolutely. And that's something that is, like I said, with the 95% protection, you still have a chance to be a carrier. And what's very interesting is that the concern is that usually are the kids bring home viruses to give to the parents. And with COVID, one thing that the researchers are looking at is there may be a reverse effect where the parents who may be vaccinated, maybe about that 5%, may be carriers and actually pass it on to their children who aren't vaccinated yet. And that's where we may see another little bump down the road as we kind of go through the phases of vaccination.
Okay. So Joel, some of my patients have been asking me about how long is this going to protect me? I've heard reported maybe a year. The data, I talked to a few immunologists. They're talking about maybe one and done. What is the data saying about this? Is how long will the vaccine protect us against this virus right now?
I don't. So what I have seen is that it's not known and the studies are ongoing. I think that most COVID-19 vaccine researchers believe that it's probably going to require more than one lifetime dose, and may even be something that is annual, like with the influenza vaccine. In fact, there's consideration and discussion that perhaps it could be bundled with the influenza vaccine if it's something that's required every year. But at this point, I don't think it's known. The studies are ongoing. With cat and dog coronavirus vaccines, which have been out for, about 10 years, there has been a need to revaccinate after a period of time. And so I think that most expect that there will probably be a need to revaccinate after a period. But what that time period is going to be, the next studies that Moderna and Pfizer tell us about over the next year.
Okay, all right. Since during Joel's presentation, we talked a lot about side effects. Prak, can you comment on, there's been some information out, if you read Facebook and their comments, they're talking about, don't use ibuprofen or acetaminophen if you get one of these side effects, because it's going to diminish the effect of the vaccine. What is your opinion about that? Can we pre-medicate, especially after the second dose, where it looks like the immunologic response is a lot higher in patients? Can we pre-medicate with acetaminophen or ibuprofen, or do you recommend one anti-inflammatory versus another?
So that's a very good question, Srini. So the initial information about not pre-medicating came from the researchers that were first looking at the vaccine, because they weren't sure what kind of side effects people were going to have and to what degree. So they actually encouraged people to not take anything, because they wanted to see how high a fever, what kind of pain, how long it lasts. But now that we have more experience with it, the reality is that people are going to want to feel comfortable with side effects afterwards, because they have to continue with their daily activities. So what we recommend to people is what typically works for them. So if they're able to take Tylenol or take ibuprofen as their pain reliever of choice, and there's no other contraindications, then it's okay to take it afterwards. The conversation about pre-medicating, basically taking it before your shot, that is still up in the air. I've talked to some primary care doctors that encourage their patients to do as they normally would, and I have other ones that say to wait and see if you really need it or not. What we recommend is perhaps to wait to see if you need it after the fact. to see if you actually need pain relief or not. But that's really the reason why the initial information said not to do it at all, is because they wanted to help track some of the side effects. So.
Yeah, and I think that other vaccines like the shingles vaccine, the second vaccine seems to bring on a larger immune response, and they do get that high fever, and in my patient population, I do recommend they pre-medicate after the second shot or before their second shot. But you're right, we were trying to figure out where it falls. Yeah,
exactly, and that's the reality, and that's actually a really good example. So for those of the audience that have received their shingles vaccine, that's going to be the closest. If you're trying to understand what to expect with the COVID vaccine, your experience with the shingles vaccine, the Shingrix, the newest one, that's what's going to best mimic what you may expect. So if you had some soreness for a couple of days, you probably had that with the COVID as well, matching kind of the first and second dose effect. If you haven't received the shingles vaccine, then it'll be a new experience for all of us.
So Joel, the next question I have is, a lot of my patients are saying, you know what, I might have had COVID, or I've had COVID. Do I really need to get a vaccine? Why should I inject, something into my body that I don't need? And what would your response to that be?
Yeah, so we actually know a little bit about this from the studies that were done on the vaccines, because in each of the vaccines, they checked for antibodies, and they realized that 2 to 3% of patients that had come to them and had enrolled in the vaccine trial had unknowingly had COVID-19 somewhere along the way, and were probably asymptomatic. But they had 2 to 3% of patients that had evidence of prior COVID-19 infection in the trials. So the recommendations are that, that vaccination is safe, and it's likely to be helpful in those patients. And they also noted that patients who had previously had COVID-19 infection, who experienced side effects after the COVID-19 vaccine the first time around, should get the second dose. So in other words, if there was a patient who had COVID-19 previously, they got the vaccine, and they kind of felt sick after it, that was not a reason to not go ahead with the second dose. I think that it certainly is true that there's a period of time in which patients who've had COVID-19 are likely to be immune from the illness. We don't exactly know what that is. It's probably at least 90 days. It looks like there's, earlier this month that it may be 8 months, it may be more, that patients that have had COVID-19 have a natural immunity to COVID-19 for a period of time. That appears to be likely to be true. Nonetheless, I think that most patients that have had COVID-19, the rationale for vaccinating is a couple of things. I mean, first, we don't know how long people are going to be immune to the virus after they've had COVID-19. And secondly, in the push to try to get as many people vaccinated as possible, I think that we just want to make sure that everyone has the opportunity to give themselves the protection that is offered by the vaccine. Because if that's 2 years of protection or 3 years, or whatever it turns out to be, that's likely to be much longer than the natural immunity that's conferred after a COVID-19 infection. So that's why the recommendation is that if you have the opportunity to get the vaccine, you can take it, regardless of whether you've had COVID-19 previously.
And what is the recommendation to get it? How long should you wait? The CDC originally said 90 days, and I think that's changed recently. So,
well, right. So the mantra that we offer for patients that have had current or very recent COVID-19 infection is that patients should recover from their acute illness, and they should have met criteria to be discontinued from isolation. So patients that have had COVID-19 can come out of isolation after 10 days if their illness was mild, and 20 days if their illness was more severe. And that's just based on data as to, when researchers were able to culture they were able to culture live virus after initial infection in patients with both mild illness and severe. So 10 days in isolation if it's mild, 20 days if it's severe. And so, the recommendation is that patients should be out of isolation and they should recover from their symptoms, and then they can get the COVID-19 vaccine. With that said, there's also the caveat that because we're pretty confident that patients aren't going to get reinfected in the first 90 days, I think, physicians should probably advise their patients that if they want to wait 90 days, that's fine. It's just really more a question of whether the vaccine is going to be available to them in 90 days if they have it available to them now. But that's where the 90 days part change.
And I unfortunately, this virus has only been around 9 months. We are getting more data as we go along. I think it was recently published that our natural antibodies were lasting about 6 months. The recent study, but it may be longer. But I think giving the boost to the immune system, I think is reasonable. Prak, for our patients that are immunocompromised or have transplants or other autoimmune disorders, what is the recommendation for the vaccine?
So that's a very good question, because that does come up a lot. The biggest thing for patients in that category is to really have a conversation with their physician, because it depends on if they're in course of therapy, if they're actively getting treated versus they're getting followed up post-treatment. So for transplant, for example, if they're years removed from getting a solid organ transplant, for example, and they can use kidney, then their immune suppressant levels may be maintenance levels, so they actually could receive the vaccine. The biggest thing to understand is that in order for us to achieve antibodies is to actually have a functional immune system to actually respond to the vaccine, to be able to have measurable antibodies and a proper response. So if you're in the midst of getting chemotherapy or immune therapy, then you probably aren't going to be a candidate at that time, barring, if you're on a unique therapy that doesn't affect your immune system or keep it in check. So that's definitely a good conversation to have. But if you have a history of, say, cancer or history of or autoimmune disease where it is maintenance and you are taking just a daily medications for it, then you would qualify. But again, it's a good time to have a conversation with your physicians to figure out if timing of receiving the vaccine for you may be more unique than kind of what the phases are that are described in kind of the literature.
Can I add something to that too?
Sure, go ahead.
And then the other consideration that I would just add to that is that, there certainly is concerns that COVID-19 itself is potentially more severe in patients that are immunocompromised as well.
Correct.
And so, whereas there's concerns, and it's in data that's probably forthcoming about the vaccine and how efficacious it is in those populations, it's also concerns that COVID-19 is not a good thing in patients that are immunocompromised. So that's the other part of the discussion that gets a little tricky. We don't necessarily have the data as to what the vaccine does, but we do know that COVID-19 can be even more vicious in immunocompromised patients. And so that's the other consideration that makes this particular question kind of tricky.
Great. Okay, I think those were the preliminary questions. Bhupesh, was there anyone in our audience that have any current questions?
No, I don't see any questions yet. So again, anybody in the audience, if you have any questions, feel free to type them in the chat.
Type them in the chat.
Or just unmute yourself and let us know if you want to speak them.
Yeah, could you comment on the variants?
Go ahead, Joel. What do you think?
Yeah. How long do you want? Do you want 3 minutes? Do you want an hour and a half? I know a lot about the variants. So I have slides on the variants. Anyways, there are 3 variants that we have concerns about. And I'm going to use the verbiage to talk about the UK variant, the South African variant, and the Brazilian variant. because there's an alphabet soup of nomenclature as to how the variants are actually described. So the UK variant, which is the B117 variant, is it is probably the most immediate and substantial concern to us in the United States, because we know that the UK variant is here. When we talk about the variants, I think it's most helpful to think about this in terms of what the epidemiologists call the R0 number. You know, when a patient is infected with an infectious disease, how many patients can we expect that person to subsequently infect? All right. So this was a big question at the start of the COVID-19 pandemic. How infectious is it? You know, so for measles, the R0 is like 14. You know, one person with one person with measles is going to infect 14 other people without interventions to interrupt the transmission, like a vaccine. Social distancing, hand washing, you know, masking, these are all interventions which can help reduce the number of people that are subsequently infected. And so the whole idea is to try and get the R0 less than 1, so that the average person who gets infected with COVID-19 infects less than 1 person on average. Because if you do that, your pandemic is shrinking. All right. So the concern for the UK strain is that it raises the R0, the infectiousness, about somewhere between 30 to 60% more than the normal, if you will, COVID-19 strain. And so because of that, you know, there's a lot more risk of people getting infected. It's just simply more infectious, and there's going to be more cases. It is not thought to be more deadly, but if there's a lot more people that become infected with this, there's going to be more deaths, even if the mortality rate isn't worse. So I think that a lot of us are very concerned about the UK variants. The vaccine appears to be still as effective with the UK variant. And so we don't have concerns about the vaccine right now with the UK variant. The South African and the Brazilian variants are a little bit different. They are perhaps even more infectious than the UK variant. And the research just out this week suggests that because of a particular mutation in the spike protein with these variants, that we may lose some vaccine efficacy with the South African and Brazilian variants. So vaccines mutate. None of this is a surprise, but it is a concern. I think it's going to keep our travel borders closed for the foreseeable future. And you know, there's data in Brazil of certain communities where 70 to 80% of people in those communities have had COVID-19 because they've had this more infectious variant. So we'll see what happens. I'm not quite sure how many patients or how many states have had the UK variant yet, but Ohio has. We had our first case in Columbus actually last week. And so, you know, we can expect that it's here, and it may eventually replace, just by selective pressure, the traditional variant as being what's more spread in the community. So I think it's a concern that this will be the theme of the next surge in a few weeks. There's a real concern that could happen.
So I was just looking at our chat function here. One of the questions, again, I think we mentioned this, but it's a reminder. The vaccine itself is only 95% protective, so it's not 100%. So we need to continue doing all the things that we've been doing all this time. So wearing masks, social distancing, avoiding large crowds. until we see a majority of the population vaccinated to be completely safe. So we do need to be careful. Then Prak, was maybe a question for you. Should patients who are vaccinated be checked for antibodies? And if so, which ones?
It's a good question. So this has come up a lot for folks thinking about the next step. So what does that mean to get vaccinated? And we keep telling everyone you'll have antibodies that will protect you up to 95%. The reality is that it's not going to be a standard of care where individuals who get vaccinated will get their antibodies checked. Now, you can foresee down the line where perhaps for travel or if for certain visiting certain areas of the world or even the country, we may have to check to make sure that you have a certain level of antibodies to have protection, but it won't be standard of care. It is important to know that, you know, if you do display symptoms of COVID-19 and you do have to get tested, it's important to let them know that you've received the vaccine, because the type of tests, when they do look for antibodies, they need to know that you've been vaccinated or not, because that will help them decide what they're measuring and to make sure that they're measuring new antibodies that are produced from infection versus from vaccine. So I don't know if it'll be standard of care quite yet, but I'm sure Dr. Kammeyer, Joel can already foresee the future where it's something, a standard question to ask and something to actually measure in certain populations, and including some of the special populations like the oncology, transplant, autoimmune world. We may need to consider that before we start treatment. So,
right, I saw a news story earlier this week that a cruise ship was requiring evidence of the COVID-19 vaccine before they would let people on a cruise ship. If cruise ships are going to operate in the next few months, I think that that's a very good idea. And I think that that's a sign of what's to come. You know, that there's going to be some sort of stipulations for a lot of activities that, especially that have close groups together, that people are going to have required proof of vaccination before participating.
And
I think
do you think that the testing, has it gotten better? Because when all of this started back in April and March, you know, when we were trying to, we couldn't get a COVID-19 test, which was like finding gold under a rock. You know, what about the antibody testing? I mean, you know, that wasn't very accurate. We had some kits that came from the UK that were giving false sense of security to people. Has the antibody testing gotten better?
So we should understand a few things when we talk about testing. I'll just kind of touch on this briefly. When we talk about, you know, the testing that has been typically used in the United States and hasn't been as available as we would like it to be over the last 10 or 11 months, we're talking about a PCR test. And without getting into too many details, the PCR is accurate. It has virtually no false positives. There is a false negative rate, but that depends to some extent on how well the test is taken, and it depends to some extent on when in the course of illness the test is obtained. But it's the most accurate test that we have. You know, the problem with it is that it's not widely available. It requires a lot of supplies and reagents, and it's pretty expensive. More recently, a second kind of test that looks at antigens has come to the market. And these are less accurate, but they're much more widely available. And so, you know, the antigen testing can be made very cost effectively. We think of it like we think of a pregnancy test, where, you know, we could even have antigen testing every couple of days because it's just a couple of dollars. And, you know, you might lose some accuracy, but the accuracy that you lose may not actually be clinically meaningful. And so one can imagine a scenario where, you know, to get into a concert this summer, that they have to, do a quick rapid antigen test in order to, prove that the patients, aren't COVID-19 positive in order to get into the door. So that might be part of the future too. For antibody testing, there are different antibody tests that are on the market that are of variable performance. And, one of the problems with antibody testing to determine whether somebody has been previously infected is that there is some difference between persons as to when, when we generate antibodies. Srini might generate antibodies after 6 days. For me, it might be 15 days. And so it can make it a little bit difficult to interpret clinically, the antibody testing. And so I think that that's why there isn't a routine recommendation to proceed with antibody testing before getting the vaccine. It doesn't really change anything for most patients.
Okay. This is an interesting question that I've never had asked before. I don't know if either one of you can answer this one. The question is, can you get a DVT or PE from the vaccine? And should we take aspirin before the shot?
Yeah, I actually can't answer that. So there is no evidence or comment upon that in the list of things that happen in the trials after the vaccination. So the 2 vaccination trials that I showed you, DVT wasn't included as one of the effects. Now, with that said, there is the National Adverse Vaccine Reporting System, and patients that have had DVTs after the vaccine, should report that, but it wasn't commented upon in the studies as something that they saw as, with any routine occurrence enough to have to be reported.
And I can concur with that too. We've had cases where we've heard of individuals who said they had a PE, but on further investigation, it turned out that they had it from other comorbidities, not necessarily from that. But as it is with any new technology, timing is everything. So people are focusing on the fact that they got the vaccine, and then if shortly afterwards they have a condition, then they're going to kind of associate that with us, and then it's our job to kind of disseminate that information. So,
and is there any harm if the patient would want to take an aspirin before the shot?
I don't know the benefit. The risk would be if they are, have a risk for GI bleed, for example, if they're not supposed to take aspirin, but they take aspirin normally as their pain reliever. There would not be anything that's contraindicated if they don't have any other reason, either clotting wise or bleeding wise, for taking it. I just don't know what the benefit would be for example, to recommend to you, Srini, before your second dose to say take some aspirin. I don't know if you'd get any benefit from it. So I think it's kind of a neutral.
It is. It's interesting. Again, it's
for sure. That information is. I mean, some of those anecdotal conversations are out there, so I think it's a very good question. So.
And that's the problem, right? We're going through the pandemic. I think the analogy that I've heard is we're building an airplane and flying it at the same time, and that's exactly what we're doing. And so, that we're going to learn things as we go along. We're making some errors and learning from those errors. But I think Bhupesh, you had a question that you wanted to.
There's a few questions in the chat. One question is, will the COVID vaccine become an annual vaccine like the flu vaccine?
Yeah, and I had kind of touched on that earlier. Probably, but it's not known. Maybe biannual, but those studies are ongoing as they're really trying to parse out exactly how long we have immunity after getting the COVID-19 vaccine.
And it may be similar to what we have with the H1N1 vaccine, that it's part of the quadrivalent flu vaccine. So if you get the flu vaccine, you get protection against H1N1, which not too long ago, if you recall, was a separate vaccination when we had an outbreak of a lot smaller scale. So it may, like Dr. Kammeyer said, that may be kind of ingrained in getting our annual shots that we get for the season. So
Okay, thank you. And there's also one more question. And I think you've answered this, but I'll just repeat it once more. If a patient has antibodies due to COVID because of a prior infection, should they still get the vaccine? And if yes, then should they wait for a certain number of days?
Yeah. So again, just to reiterate, the new guidance is to let the acute illness pass and to come out of isolation, which is 10 days for mild illness and 20 days for severe illness. But it's also true that if patients want to wait for 3 months, for 90 days, they're likely to still have some natural immunity during that time. It just becomes more a question of, will they have the opportunity to get the vaccine on day 91? And that's, I think, part of why they recommend to just go ahead and get it if your illness has passed and if you're out of isolation.
Okay, so I know we didn't talk about this during our presentation, but it looks like there's a question about this, so I want to bring this up. Pregnancy and while breastfeeding, what is the recommendation as far as the vaccine?
it's recommended. So unless the OB for various reasons, so they have other underlying health conditions and that they're not considered a typical patient that's pregnant, then they recommend getting it. It's all like with all vaccinations, it's always good to have that conversation with your OB to make sure that they're aware of it and if they don't have any specific concerns just for you individually, but there aren't any data showing that it's contraindicated at this time. So.
Yeah, and Srini, if you didn't bring up this question, I was going to, because my goodness, I think that this is the most commonly question that I'm stopped in the hallway by nurses to ask. There were a tiny number of patients in the 2 vaccine studies that have become pregnant in the time after the vaccine studies. And so they're going to look at those patients to make sure that everything went okay. Pregnancy was an exclusion criteria in both studies. And so they didn't study pregnant patients. And I think that we have to tell our patients that they weren't studied. And those studies are now ongoing and that data will be forthcoming. I make 2 points because I fully agree with Prak that, this is a conversation that patients have to have with their obstetricians. I would make 2 points. One, with the way that the vaccine is, with the way that it works, with it creating this like mimic spike protein in moms, I can't imagine what effect that would have on the fetus and on the baby. So that's the first point that I would make. And the second point, I looked up after having gotten this question. As of October 1st, the Pan American Health Organization, okay, so the regional office of the WHO that evaluates North and South America, they had commented upon that they had had 458 mothers as of October, so it will be more now, 458 moms that had died of COVID-19 during pregnancy. And so, with whatever concerns we might have about the vaccine itself, we have to recognize that, pregnancy is another patient population that is maybe vulnerable to a little bit more of a serious course of COVID-19 itself. And we have to keep that in mind too as we're making these decisions.
And one more thing to add is that, and this came from an OB I was talking to this question about. They said one of the things people need to understand is that the viability and the optimal health of the mother is going to give us the best outcome for the baby. And I think that's, if it is the vaccine is going to protect the mother the most, and that's going to be only the positive outcome for the baby. So that was their position. They said, we don't have all the information, but the OB said to me, they said their goal is to keep the mother as healthy and optimal as possible. And that's what's going to be the best for the child. So
Perfect. So one of the questions that was brought up, and it might be related to the fact that the recent CDC guidelines changed, and so we're in this crunch of, where can I get this vaccine? Are they running out? So CDC just came out and said, okay, you can wait 6 weeks now. What is the true optimal? Is it 4 to 6 weeks for the Moderna? And what happens? What about the Pfizer? Because Pfizer was 3 weeks. Has anything changed from your perspectives that we could actually go out to 6 weeks?
Not optimally, yeah. No, I was gonna say, so if you recall, Pfizer, based on their data, it was first dose and then second dose was 21 days later, and that's how they got the results. And then from Moderna, it was first dose and then 28 days later. So when you go in to get your shot, they automatically schedule you for your next shot, which is very important because they allocate that for you. So when it's your turn, it's allocated. New data just came out probably within the last 48 hours from Moderna showing that if need be, you can go out to 6 weeks. It's because they found some scenarios where individuals, due to various reasons, logistics, availability, health, etc., went beyond the 28 days. And that's how they guesstimated that up to 6 weeks should be okay. However, it was just observational in a small subset of individuals. So right now, their goal is to get everyone, Moderna to be within 28 days and then Pfizer 21 days. There's some discussion about getting just one dose and kind of getting the second dose later on, whatever that generic later on is. But then the point is we're missing out on matching that 95% protection. So I think as we start manipulating timelines, we're going to lose out on getting maximum effort and maximum protection. So I think.
And what would happen if, let's say, I got dose 1 tomorrow, and then I couldn't get a dose for 3 months, second dose?
Yeah. So you probably will not get 95%.
Do we start over? Do we start over?
That's the question, is the whole priming, because you'll probably want to start over, but you may be in line to get like a third booster. I mean, that's when they'd have to check antibodies, right? Joel, I think that's probably more work for you, right?
Well, we're about to have a massive real world experiment on this, because this is what they're doing in the UK. So as a response to the fact that, particularly in southeastern England near London, that the B117 UK variant has just caused an overwhelming, spike in cases. Earlier this month, at the first part of the month, the UK government decided that they were going to take their vaccine supply, try to vaccinate twice as many overall people, but not give the second dose, and they were going to delay it for 3 months. And so, we're about to see a real world application of this and what happens. I think a lot of the research scientists are saying, that might work, but the problem is that we just don't know, because, that's not how it was studied. And so, their premise in the UK has been that it's better to get more people vaccinated, even if each individual's personal risk isn't 95%. Let's try to get as many people possible as we can vaccinated. That hasn't really come up in the United States, in no small part because we're not even able to kind of adequately use the supply that we have right now. We don't have strong enough vaccination programs to get through the supply that we have. But we're going to see what happens when it's delayed. And I have a lot of nervousness about what they're doing in the UK, but we're going to see. So.
If I can add to that,
I think, I'm sorry, go ahead.
No, sorry, Sri. And to add to that, I think the reason, and Joel gets to this, is that why it's not standard is because of two things. There's two trains of thought. There's one that, if we can get 70% protection, that's better than zero, right, with the one shot. But the counterpoint to that is, are we increasing our risk for more mutations and variants? And we'll have not just one UK variant that misbehaves, we'll have 5 of them. And then each part, not just like one variant in the US, but we'll have like regionally maybe in Ohio we'll have 2 different variants and they may behave differently. So the question is, because it's so new and we're trying to understand technology, we try to match best as what we've measured and we've followed strictly with the studies, because that's how we can best replicate and expectations. Versus if we start making up our protocols, like Joel said, it's very nervous because fingers crossed, it'd be great if we can get 70% versus 0, but what are we on the back end? Are we causing, our worst enemy? We're actually making more work downstream, and we don't know the answer yet. So that's to back up what Joel was saying and add to that was that we're actually increasing the number of variables if we start going away from what we know. So.
Yeah, it reminds me of in HIV, you need to give HIV patients 3 drugs. If you give them 2, they're going to do better. They're going to get somewhat healthier, not as healthy as they would be for if they got 3 drugs. And patients that get 2 drugs are going to develop new resistance. It makes me nervous. It makes me nervous, the idea that we're going to do this in an incomplete fashion in the UK. Because of resistance issues, just like Prak says. Yeah.
Well, I am eagerly waiting for the Johnson & Johnson study results to see what that vaccine is going to give us. And it'd be nice to see that we have a 3rd entrant in our pool of vaccine availability. And if that happens, maybe by April, we do have a higher number of our population, and we're not fighting over the 2nd dose of the vaccine. One more, there's another question, and I think this is actually for during the treatment arm. It's not the vaccine related. It looks like it's more related to when somebody has mild symptoms as an outpatient of COVID-19. Has there been any changes of when you should use steroids? When should your patients or my patients call and say, "Hey, I need to go on steroids"? Or are we still the same? Has anything changed?
Prak, I'll let you go unless you want me to.
I'll tell you this. So from the outpatient setting, what we're finding are individuals that were started in the hospital. When they go home, they're just continued on 7 days and then tapered off of dexamethasone. Very few patients we've seen in the community setting have been put on steroids, I won't say indefinitely, but for like a long period of time, because there are some risks benefit with that. So typically the ones that did respond inpatient were continued outpatient as well. And I think each ICU has their own protocol. And I think we know that steroids, most specifically dexamethasone, has really showed to be what's most beneficial. That I think the patients that responded to that positively have kind of continued it because they're trying to get patients out of the hospital sooner because of limited resources, as well as longer the patients stay in the hospital, the greater chance there is for other things to occur related or unrelated to COVID. So, Joel, I'm not sure if you see anything different than that.
No. Yeah, so steroids are recommended. The data is for severe disease, and the data isn't really there for mild disease. With that said, anecdotally, there are, I think, a lot of patients that are getting steroids for mild disease because once you've been diagnosed and you've started to get a little short of breath, what else really is there to do for you in those early days? There's actually an answer to that question. I'll get to that in a second. But steroids are pretty easy and straightforward. And in fact, I've even given some colleagues and friends and patients some off-label steroids during those early days, just trying to prevent them from progressing, just because it feels like our options are pretty limited and you're waiting for things to get worse, which is a little unsettling. But the data isn't really there to do that. That's an off-label choice. There are medications called monoclonal antibodies. And, the one that was made famous is by the company Regeneron, because that's what Donald Trump got in October. The other is bamlanivimab, which we actually have a little bit more access to. And, the monoclonal antibodies seem to do well in patients that are early in their disease before they're requiring oxygen. So we have to give these, kind of sophisticated medication infusions before patients are actually sick. And the populations of patients that can receive these is somewhat limited. It's either 65 or older, or it's 55 to 65 with some comorbid conditions that suggest that they could progress and have more severe disease. So, the problem with administering these is that it's not readily available to just give someone an infusion of these medicines during the first few days when they're not sick. Most doctors' offices aren't equipped to do this. At ProMedica, and I think at UP as well, they're administering it in the emergency department, but that means you actually have to go into the emergency department when you're not requiring oxygen and you're not that sick in order to get the infusion. So, we have that as an option, but again, the distribution and the mechanics of getting it out there has been difficult to solve.
Right.
And I think the definition of mild disease and severe is the ones that are requiring oxygen, that require hospitalization, correct?
Right, exactly. And it's not an unlimited resource either. So I think biggest question is, the expectation shouldn't be if you did have to go to the hospital that you wouldn't necessarily be qualified to get this monoclonal antibody treatment, because it's not an infinite resource as well. So that's something to consider. One of the challenges that our critical care folks have is trying to figure out who gets what resource, and that's a big challenge, right?
I think there was 30 doses at St. V's and 30 doses at Toledo Hospital in our community. 60 doses of this drug. So it's not like it's not coming out, left and right.
Yeah, nationwide, the comment is that there are supplies that haven't been used, but again, in different pockets, there's different availability.
Bhupesh, you had a question?
There's one more question that came in. How would you convince your patients who do not want to take the vaccine? And I'll add one more twist to it. Are there any certain patients who are not good candidates for the vaccine?
So I can make a comment on that. This, again, I was doing one earlier this week, and this came up a couple of times. So I'll tell individuals, but the reason that we're trying to get the vaccine is because a lot of us want to see some progress in how we're living life now, in terms of being able to see friends and family, access to simply going out for dinner, access to seeing friends and family. The reality is that it's going to take a while for all of us to get vaccinated. But if you can think of a group of, say, like 5 family members that are vaccinated, then the 5 of you can go and meet together and have dinner at someone's house, and without masks, if everyone doesn't have symptoms, and actually kind of feel like you're back to how it used to be, which it'll never be that way again, but it'll feel more like going back together and seeing family. Now, the challenge is that everyone has to be vaccinated. It has to be small, but say you're together, you're meeting, it's something that you can feel like you're back to normal. Now, once you leave and say you're meeting at someone's house for, say, a holiday, and then you decide to go out to dinner, then you'd have to all wear masks and make sure you're socially distanced, make sure you wash your hands. So that component is still always going to be there. The biggest thing is that that's a real life example of by everyone getting vaccinated, then you have more options to be able to interact with one another, because we are social creatures, and I think is important for us to do so, and that will definitely help the mental health component of what this pandemic has done to the country and worldwide as well. So I think one thing for people who are unsure, they got to think about you can't have one without the other. So I think by doing it, we're actually helping society and community, as well as being able to expand what we're able to do. But if you involve family with kids, that adds another variable where kids aren't going to be vaccinated for some time, because Moderna data won't be out till next year. So it's not as simple as like, oh, we're just going to get all the grandkids and all the children and all the cousins together. That won't actually happen, and that'll be still ways off. But it is a step in the right direction to be able to get back to how we want to live our lives. And as Indians, we're very social, so it's very difficult for us to actually be able to be responsible and to be patient with not wanting to see friends and family within our community as well as, around the country and around the world. So.
And I think the biggest fear was probably caused by our politicians. I think politics entered into science and it should have been separated. And I think my patients fear that, all this was rushed and that we're all guinea pigs, and the big thing that I tell my patients is, the mRNA vaccine wasn't developed in the last 10 months. This has been going on for the last 20 years. And COVID came along, they figured out the genetic sequence, then they were able to plug it into the mRNA vaccine, which they were going to probably release in probably 2 to 3 years. So it accelerated this new technology, this vaccine that we can utilize against viruses. So, and that usually puts them a little bit at ease, and I think, and obviously we all have to lead by example. I think all of us, the panelists, have got vaccines. I think all physicians should get vaccines. All the nursing needs to get vaccines. It's hard, it takes time in our day to convince people, but again, what Prak said, we're trying to get back to a normal life, and this is the first step in that direction.
I have a friend who's out in Boston who worked on Ebola vaccination programs in 2015 and 2016. And he was on Twitter last week and had a thread that went viral, if you'll excuse the pun, and really talked about how, it's not vaccines that save lives, it's vaccination programs that save lives. And that it really requires, the one-to-one interaction. I'm trying to do as many forums as I can to kind of talk with people about their questions and allay their concerns, but it really does require that. We can tell people to, watch Anthony Fauci on TV or to go to the CDC's website, but when people are communicating with others that they know and trust, that is the single most effective way to convince someone to take the vaccine. It's not Anthony Fauci on television. It's us in our community saying that, look, I had a good experience. I'm feeling confident that I'm going to be able to interact with my family. I'm doing it for the better good of society. Those are the kinds of real world applications that we all can take part in to overcome vaccine hesitancy.
Right, and can I add one thing too. Part of the hesitancy is for people to realize this is new technology, and that's what we're learning about it. And this came up in a question answer forum, like I said earlier this week. I did where someone in the audience made this example because this question came up a few times, and people just weren't convinced. They said, those of us that so you hear about people driving a Tesla and they put autopilot mode. So people are willing to drive a car and let the car keep them, in the right lane and drive for them, and they're completely fine with that. But they're questioning this, and they have to realize that this is new technology, and as we get more information. One thing I think, and this may be a part with administrative change, we're trying to share as much information as possible. So as soon as we got information about the variants that Joel mentioned and how the viruses are changing in certain parts of the world, that's getting shared. So all of us are getting real-time information. So with technology, it's great that we have to understand that it's new. We don't have all the answers, but as we get information, you have to be comfortable that it's going to be shared, and that's how decisions will be made and changed. And Srini, Joel, myself, as we get information, this is the information we'll share with the community, and that's something to be really happy with, right? Because a lot of times you don't want to wait to get results. And it's nice to know that as we get information, we can share that and then make changes on the fly, which is why these vaccination programs will become effective and success is possible. So.
Okay, sounds good. I think there's one last question that we probably have not answered, and then we can wrap up. Does the 95% efficacy apply to the variants also?
It appears that the UK variant that is likely to be the case. You know, with what they're learning about the South African and Brazilian variants, it is not known, but there are concerns that it may not be the case with the other variants. And that's preliminary studies from this week that people like Christian Anderson and others are just starting to take a look at. But there is concern about what they call it. They have a name for it, immune dropout, with the South African and Brazilian variants. So to be continued.
And that's the example. Like, as we get information, more of this is coming out. So I think it's a very good question, and we don't have all the answers. But as we're learning, that's why you're kind of wondering, why is there always ever changing, you know, guidelines and information and suggestions? Is because as we get information, we're updating as we go. So
using my plane analogy, the engine is starting to rev. We're about to take off. The wings are in, but the rest of the plane is still not ready yet.
Yeah.
So
sounds good. So I thank all three of you for taking time and sharing all this information with us. It was very interesting and very informative. So thank you so much.
Thank you for the invitation.
Thank you for having me.
good night, everyone. Thank you.
Good night.
Take care. Good night.
Thank you.
Thank you.
Bye.
Bye.